Fine.
Hey guys, good morning. So we're going to talk about clearing the pediatric C-spine. We do see these cases pretty frequently. There's minor tremors come in. Maybe they complained of some kind of pain on their back or neck, and the EMS, as precaution, puts them in a C-collar, and we're going to talk about how to get them out of the C-collar safely. All right, so we'll start with a small scenario. So EMS presents with a child and both parents for evaluation. The parents say that they were playing and they were videoing. They're making a family video in Brooklyn, and shortly after making the video, the child began to complain of some pain and was hesitant to move his head. So the parents became concerned and they called 911. They have the video on their phone and they want to show it to you. See if it plays. Oh, sweet. So there's their baby. Mommy jumps, and then baby decides to jump. So they were able to show you the close-up of the video. He's still smiling. He's still happy. So I don't know how to... Ronnie, how do I get out of... Oh, there you go. We're back. All right. So they showed EMS this video, and EMS put him in a C-collar. The child otherwise looks comfortable with normal vital signs and a normal mental status. You undress the child. There's no other signs of injury. Your fast is negative. You remove the C-collar to try to clear his neck, and he is hesitant to range his neck to the left. So you place the C-collar back on. And now we're going to talk about the rest of the goals for our lecture today. We're going to go over the anatomy of the pediatric C-spine, pathophysiology of C-spine injuries, why the cutoff is at 14 and not younger, some recently published literature in 2019, and if we have enough time, types of C-spine injuries, different types of C-spine injuries. So why does it matter? Why are we talking about this? Pediatric C-spine injuries account for 1.8% of pediatric injuries, and when they are present in younger children, they do tend to be more severe. The mortality rates with pediatric C-spine injuries can be as high as 26% in children under 2 years of age. The most common cause for C-spine injuries in children is motor vehicle accidents in children less than 2 years of age. Also, falls, sports injuries, pedestrian strokes pedestrian stroke is the most common cause in older children and young teens. And when you get to your young teens and older children, you have to think of assault and gun violence. Children do have larger heads and a different fulcrum point for their C-spine injuries. And there really are no algorithms when we think about pediatric C-spine. Nexus and Canadian rules, not truly validated in children, although there was some studies looking at the Nexus. And Canadian C-spine had no children in their study, so you really can't use it. Nexus had 30 children with clinically significant C-spine injuries. So, and they have some algorithms some validation that we'll talk about. So, looking first at the anatomy, we'll look at C1 anatomy. You have 3 primary ossification sites between the 2 bodies and the anterior arch. The 2 bodies, your neurocentral syndrochosis, these fuse by 3 years of age. Those arches are fused, and down here, sorry, these arches are fused down here by 3 years of age, and they form the posterior aspect of your spinal canal. And the anterior portions of the bodies fuse with the arch. They should be fully fused by 7 years of age. And this is important to know when we're getting imaging on younger kids. So if you're seeing openings here after 7 years of age, or any kind of defect or lucency in this area after 7 years of age, you should consider that pathologic. but before 7 years of age, it may just be not fully fused yet. And after 3 years of age, any lucency in the midline of the lateral bodies should be considered pathologic. So looking at your C2 is a little more complex. It has 4 ossification centers. Again, the posterior aspect fuses by 3 years of age. By 3 years of age, you have the C2 body, which fuses to the neural arches. So you have the body here of C2, and the arches that fuse by 3 years of age, between 3 and 6 years old. You have your subdental syndrocosis, which is the part between the body and the dens. That fuses by 10 to 11 years of age. And this is important because you may see a lucency there in kids between, if you get a CT scan, and if there's a lucency before the age of 11, it may just be that syndrocosis. But if it's after any lucency in that area, in this area here between the body and the dens, after the age of 11, you should consider it pathologic. And in terms of the rest of the cervical of the C-spine, C3 through 7, they have similar anatomy with the centrum and with the body and the neural arches. The arches fuse, the posterior aspect of the arches, they fuse by age 3, and the anterior portion fuses between 3 and 6 years old. You also get secondary ossification centers, essentially growth plates of the transverse and spinous processes that appear later in puberty, and these can also be present up until the 3rd decade of life, so late 20s, early 30s, and these are the centers of your secondary growth plates at the transverse processes and the posterior spinous process. So in blunt trauma, there are some important things to consider for our pediatric patients. Number one is that pediatric C-spine is hypermobile, and the bones are more pliable, like all the rest of the bones in our pediatric patients. They are more pliable than adults. So they're less likely to have bony injuries, but more likely to have spinal C-spine injuries without radiographic evidence. So after 8 years old, the bones begin to stiffen, and then after 8 years old, you're more likely to see bony injuries between these ages. And there's a combination of a relatively larger head size and C-spine hypermobility changes the fulcrum point of C-spine injuries in our pediatric patients. So whiplash injuries in pediatric patients will affect between C2 and C3. And at around age 14, the fulcrum changes and shifts down. It becomes more similar to adults. And so the fulcrum of injury shifts down more between C5 and C6. And so this is why when we think of trauma, this is one of the reasons why age 14 is over 14 years old can be considered as adult, because children truly do become more similar to adults. This study was done in 2011, and this is done by PCARN, and it found 8 distinct risk factors for C-spine injury, for clinically significant injury of the C-spines. It was also this other study published in 2019, January 2019. This was an expert panel of pediatric emergency physicians, pediatric radiologists, pediatric orthopedists, and pediatric neurosurgical physicians who are attempting to create an algorithm based on the available literature and expert consensus. And another study from July 2019 was a prospective observational study done looking at the PCARN data and also a new tool with, again, looking at previous literature and expert consensus, looking to develop a reliable and validated algorithm for pediatric C-spine clearance and injuries and evaluation. So when we think of the studies, the PCARN results that were done in 2011, they came up with 8 risk factors. So they have altered mental status, focal neurologic deficits, persistent neck pain, torticollis, a substantial torso injury, conditions predisposing to spinal injury, such as Down syndrome or ankylosing spondylitis, or an axial loading injury like diving, and high-risk MVAs. So persistent neck pain or difficulty moving the neck in any direction is concerning and should warrant, should make you think of imaging or deeper evaluation. And torso injuries were really the only injury location done with this study in 2011 that had a strong association with C-spine injuries. And like I mentioned, Down syndrome and ankylosing spondylitis are conditions that are higher risk to have C-spine injuries. So in 2019, like I mentioned, this pediatric working group of C-spine injuries got together to attempt to create an algorithm based on expert consensus and reviewing the available literature. They did this by the Delphi method, which was essentially surveys and some in-person meetings of the group together. So this group consisted, like I mentioned, it had 15 pediatric orthopedic physicians, 3 pediatric emergency medicine physicians, 3 pediatric neurosurgical physicians, 2 pediatric trauma surgeons, and 2 pediatric radiologists all got together. So we're gonna break this down because this is one of the things that's currently in a working progress of what they're trying to do, what they're trying to make as an algorithm specifically for pediatric patients. So the first part of this is if the patient has, it's all based on GCS. So if the patient has a GCS of 14 or 15, and the child, when you think of your history, there's a child reporting persistent neck pain, presenting with an abnormal head posture or hesitancy to move the neck, or if there's any history of focal neurologic deficits or sensory abnormalities. On your physical exam, like I said, torticollis, abnormal head position, midline C-spine tenderness, limited range of motion, or unable to, or distracting injuries. Okay, so looking at these, based on this consensus, actually the first line of imaging that was recommended by this group is X-rays. Cross-table lateral X-rays are appropriate and should be the first, based on this group's recommendation, should be the first line imaging in the pediatric patient who is stable. Spine, before getting a C-spine, before getting a CT of the spine, they do recommend consulting a pediatric spine service if available at your hospital. And if there's a history of diving or other axial load, hanging injury, clothesline injury, high-risk MVAs, these would warrant further imaging and with CT. And you should not clear the C-spine if there's a known substantial injury to the torso. Based on this group's recommendation, which is different from the 2011 study, if there's significant injury to the torso, pelvis, or the child has distracting injuries, you can't clear the C-spine. So, you know, if your X-ray is normal, they recommend, like I said, consulting the spine service before obtaining CT scans, because I don't know if you're able to do it, you should obtain flexion extension radiographs, which we'll go over, C-spine flexion extension radiographs, which we'll look at those and go over more how those are done. Or you can maintain them in C-collar and have them reevaluated in 2 weeks if you can obtain reliable follow-up. So going on to the second part of that algorithm, your patients with GCS of 9 to 13, we're going to talk about the patients who you anticipate will improve their GCS status to 14 and 15. Again, they recommend that start with a lateral X-ray. If it's abnormal, speak to the spine consult, the spine team, if there's available, or get pediatric, get a C-spine, get a CT of the C-spine. The reason they say with the spine consult, getting the spine consults first is because the CT might not be necessary at the outset if you think this patient has significant imaging, and if possible, they actually recommend potentially getting an MRI of these patients. So if you think they're going to return to a GCS of 14, these are your intoxicated children, or your children who maybe initially are distracted not due to injuries, but due to just anxiety of the situation. They're stressed, they're scared, and they're not really paying attention. So it's not really that they have distracting injuries, they're just nervous. These are the kids that we're considering can return to GCS of 14. And if you don't think your patient's going to return to a GCS 14 or 15, then we'll go to the last part of this algorithm, which is any patient with a GCS score less than 8, they recommend getting the CT off the bat. If it's normal and you anticipate the patient will return to baseline within 3 days, you can repeat your clinical exam in that time after admission. And if it's normal, you can clear the C-spine. If it's abnormal and they've returned to their GCS, you can kind of follow the first part of the algorithm, which is getting a spine consult and potentially getting CT next. And if you don't think they're going to return to baseline by 3 days, you should start with a static MRI of the neck, of the C-spine. So Leonard et al. This is another PCARN study. This is the same group who did the initial study in 2011, looking at looking at the Nexus criteria and building upon from that and finding their own risk factors. They evaluated. This is setting the foundation now for making a specific pediatric C-spine algorithm. So they evaluated our PCARN findings and they compared them to a new model that they created. The new model showed that risk factors from the initial evidence that they looked at showed that PCARN was accurate to detect cervical spine injuries with a sensitivity of 95%, but a specificity of 45%. It also showed that physician gestalt on which child was low risk for clinically significant injuries was very inaccurate, and that after validating these tools, they needed more studies. We need to do a larger study, and that's what they're in the process of doing now, of working with this group and this algorithm to make a larger prospective study to look and validate this algorithm. So looking at, when we talk about, since the first recommendation is to get a lateral neck x-ray, it's not something we typically do, so we're just going to go over a little bit of the lateral neck x-ray and what we're looking at. So you have, in children, the neck x-ray tends to be better quality when compared to adult, and the number of significant injuries missed by x-ray is less in children, significantly less in children when compared to the adult population. In the PCARN cohort, the x-ray was 90% sensitive. So a cross-table lateral view by itself is adequate for initial evaluation. If you can get the other views, in being an AP view, an open mouth view, to allow for evaluation of C1 and C2 in children who can cooperate, or you can do a Waters view through the foramen magnum in children who are unable to cooperate with the open mouth view. Those are extra views that will help increase the performance of your x-rays, but they're not necessary for the initial evaluation. And so when you're thinking of the criteria to clear for on the lateral view, all vertebrae from C1 to T1 they should be visible They should be clearly visible. So they're just talking about the quality of your image right now. They should be properly aligned in the 4 planes. So when we think of the 4 planes, we have the posterior spinous line, the spinal laminar line, which is different from the facets. The facets are here in between the spinal laminar line and the posterior vertebral line and the anterior vertebral line. So these are the 4 lines you should be making. You should be looking at when you're evaluating a lateral neck X-ray, and they should all be aligned. If there's any malalignment in any of these lines, you should not clear based on the X-ray. And the predental space should be about 4 to 5 millimeters. There should be no fanning of the spinous processes, because that could be a sign of posterior ligament disruption, and no vertebral body fractures or density abnormalities. And so your flexion and extension views, so these are your flexion and extension views, and these can help you to evaluate for patients that you think who may have ligamentous injuries. So again, these views should be performed in patients who have normal mental status and have no evidence of bony injuries or neurodeficits. If your patient, because you are manipulating the C-spine, if there is neurodeficit and they have or any altered mental status, you should not perform these tests and just keep the patient in the C-collar. Performing these tests are going to be dependent on a few things, including your radiology tech, if they're comfortable. If they know how to do this, if they're comfortable doing it. If they call and say, I don't know how to do this, I'm not comfortable, don't pressure them to do it. Just don't do it. It can be held off. You can do it at another point.
And one of the important parts about that is to let the patient do the motion. You don't push them into flexion or extension. You tell them to do it. Because theoretically, they're going to stop if they feel pain or if they start to develop a neurologic deficit while you're doing it. But you don't do it yourself, you don't flex them, you tell the patient to do it.
Okay. So we're going to look at, these are normal images of the C-spine, and it's how they varied by age. So image A, this is a neonate. Image B, sorry, I can't see the message. Image B is a 5-month-old infant. Image C is a child who's a year and a half child. D is a 2-year-old child. E is a 5-year-old child. And you can see when you get to the 5-year-old and the F, who's the 8.5-year-old, you can see the difference that this line here, this lucency, is no longer there because this fuses after 7 years old. And G is an 8.5-year-old child, so just E is a 3-year-old child, F is a 5-year-old child, so you said this fuses between 5 and 7 years old. G is an 8.5-year-old child, I apologize. You see the head of the dens now is forming and beginning to fuse. And H is a 14-year-old child, very similar to an adult image. So again, it's just important to become familiar with what the different age groups and different what you'll see on a CT on imaging of a child, so you know what age and what you can expect to see in that, and what's normal, what's abnormal. So we're going to talk a little bit about fracture of the dens. So we have different types. So type 1 is a fracture of the tip of the dens. Type 2 is a fracture of the base of the neck. And type 3 is a fracture that extends into the body of the axis. Children who are less than 7 years old, the fracture will usually be at the weakest point, which is going to be at the dens body complex. So it's going to be right around here. This is the dens body complex. Okay. True fractures of the odontoid process, they usually happen after 7 years old when it's and types 1 and 2. So fracture of the tip or fracture of the base of the dens, these are considered unstable fractures, and they do require significant force to happen. And your type 2 is going to be the one that's most commonly associated with neurodeficits. And your type 3 fracture of the odontoid process extending into the body really has the best prognosis and has no neurodeficits associated with it. The things that can go wrong after fracture of the type 2 fracture is malalignment of the dens and long-term neurologic deficits. So this is just another image, just looking at the fracture right here, and on the AP view you see the fracture again right over here. Okay, and this is again a fracture going through the body, through the base of the dens. Okay, so now I'm going to look at some other common C-spine injuries. This is a cocked robin abnormality. This is a torticollis. This happens after C-spine injury, and it's associated with a this positioning is associated with atlanto-rotary injuries. Atlanto-axial rotary injuries. So these happen in with low mechanism injuries. So they can occur while positioning for head and neck surgeries. They can happen after in the setting of a oropharyngeal infection. It's called Grizzle Syndrome, and so they present with this abnormal position. They don't have neurodeficit. They just have an abnormal positioning of the head, and they can't fix out of it. And treatment for these is pain control and rigid C collars. They can be diagnosed with plain films, but if there's any difficulty diagnosing them, they should be diagnosed with what's called a dynamic CAT scan. And this is a CAT scan first at rest in the neutral, then in the neutral position, and then rotated to the contralateral side from the abnormal positioning of the head. And these deeper images, you can reserve this imaging for patients who don't improve after 2 weeks of C-spine immobilization. And again, this is just another view. So, and those are my potential C-spine injury children who spend more time upside down. So right now, really the closest thing to a validated tool is the Nexus criteria for C-spine clearance. Really nothing else is validated. So, there are a lot of things in the works, a lot of algorithms. There are various algorithms that are in the works that are being pushed forward to be put into practice so that they can be validated, so we can have a better algorithm for children to reduce exposure to ionizing radiation. Just important things to remember. One of the reasons it's so important is that kids get placed in C-spines a lot because people are generally scared of children when they're hurt. And just the mere presence of a C-spine increases the risk of being exposed to CAT scans and ionizing radiation. So, like I said, if you're going to go with the Nexus criteria, use your Nexus criteria. If there is pain and you're not sure if it's midline or paraspinal with some midline, give them some pain control first and then reassess them. Because a lot of times it's paraspinal, but the kid is anxious. They're just got into some kind of trauma, so they're nervous, they're scared, they're most of the time not with their parent. So, they're going to be more anxious and more prone to say everything's hurting. So give them some pain control, wait for the parent, let them calm down, reassess. And if you do have persistent midline pain, even after adequate pain control, consider imaging them. And in children, if you have no neurologic deficits and you have low suspicion, you can start with a lateral neck X-ray. Any questions?